completed the antiplatelet drugs. Means we have solved the problem whenever there is thrombosis taking place in arteries. But whenever thrombosis takes place in veins, then what is the solution? We know we have got antifibrin drugs, because here deposition of fibrin, insoluble sweat, is more in veins. And for treating deep vein thrombosis or deep vein thrombosis and thromboembolism in veins, we need to give antithrombin drug. Now we know over the platelets there will be deposition of fibrin, okay, and fibrin is mainly produced from the coagulation pathway. So the drugs that will inhibit the formation of this fibrin are also known as anticoagulants, okay. So basically antifibrin drugs means we need to study anticoagulants, okay. So we will be studying anticoagulants for now. Okay, so anticoagulants means these are the drugs that will inhibit, that will have some kind of hindrance in the coagulation pathway. And why we want anticoagulants? Yes, we want anticoagulants to dissolve the thrombus which is formed in the veins. Okay, now anticoagulants can be broadly divided into two parts. First one is oral anticoagulants, and second one is parenteral anticoagulants. Okay, so we'll start our discussion with oral anticoagulants. And you know the meaning of oral anticoagulants means these are the anticoagulants which are taken via the oral route. Very simple. Parenteral anticoagulants means these are taken via the parenteral route. Now this oral anticoagulants, we have got three classes of drugs. The first one are vitamin K antagonist. The second type of oral anticoagulants are thrombin inhibitors. And the third type of oral anticoagulants are direct factor 10A inhibitors. Direct factor 10A inhibitors. So we'll discuss about these type of oral anticoagulants one by one. So starting with vitamin K antagonist. Alright, so we'll start our discussion with vitamin K antagonist, and the most important drug coming under this category is warfarin. Okay, so warfarin is vitamin K antagonist. Now we shall check out the mechanism of its action. Now suppose this is our liver, and you know in the liver all the clotting factors are being synthesized. We have got 13 coagulation factor, 13 clotting factors, and all the 13 clotting factors are being synthesized in the liver. Among those 13, I will be writing 4 clotting factors. They are factor number 2, factor 7, factor 9, and factor 10. Okay, and we need to activate these factors. Okay, we need to activate factor number 2A, factor 7A, factor 9, and factor 10. We need to activate these factors, and for activating these factors we require an activator, and that activator is nothing but vitamin K. Okay, so basically what this vitamin K is doing, vitamin K is activating these factors. Okay, so how it activates means these factors contains a decarboxylated glutamic acid. Okay, decarboxylated means without any kind of carboxylic acid. So basically vitamin K will provide carboxylation to the amino acid present inside these factors, because of which it will get activated. Okay, now what warfarin is doing? Yes, it is a vitamin K antagonist. So it is basically antagonizing vitamin K. When vitamin K is getting deactivated or it is getting inhibited, then what will happen? There won't be activation of factor 2 7, 9 and 10, and these all factors are very much important for producing coagulation of the blood. Okay, so basically what is the mechanism of warfarin? Yes, warfarin is inhibiting vitamin K, because of which these four blood clotting factors are getting inhibited. This is a very simple mechanism of action of warfarin. Now another important thing that you need to know about warfarin is it will just inhibit the activation of these four factors. It will not inhibit the already activated factor. So whatever factor number 2, 7, 9 and 10 which are already activated, it will continue to produce their action. And after some times when these activated factors are diminished in number, the further activation of these factors is being inhibited by warfarin. Okay, so what does it means? It means that warfarin cannot produce quick action. It requires nearly 4 to 5 days to produce its action. Okay, now among these factors, factor number 7, it has got a very shortest plasma half-life of just 6 hours. So whenever warfarin is given, the level of factor 7 will diminish first. This is followed by the factor 9, whose half-life is just 24 hours. Okay, then factor 10, whose half-life is 40 hours, and lastly factor 2a, whose half-life is nearly 60 hours. Okay, so though the synthesis of these clotting factors diminishes within 2 to 4 hours of warfarin administration, anticoagulation effect develops gradually over the next 1 to 3 days as the level of clotting factors already present in the plasma decline according to their half-lives. Thus there is always a delay between administration of warfarin and production of anticoagulant action. Okay, so few important points regarding warfarin. First point is we are consuming warfarin orally, so it is a kind of oral anticoagulant. Second thing, we know the mechanism of action of warfarin, that is it will mainly cause inhibition of vitamin K. Next thing is warfarin will not inhibit the already activated factors. Okay, it will just inhibit the activation of the factors, but the factors which are already activated, it cannot be inhibited. That means there will be a delay in the action of warfarin. It will take nearly 3 to 4 days for producing in production of its action. Next, since there is a delay in the production of the action, means we cannot use it for acute thrombosis. Okay, we cannot use warfarin for the treatment of acute thrombosis. So mainly we can use warfarin for maintenance purpose. Okay, now there are two types of uses of anticoagulant. One is in vivo use and second one is in vitro use. In vivo use means if we want to inhibit coagulation inside our body, that is in vivo anticoagulant. In vitro means outside the body we want to prevent coagulation. Now outside the body means yes, we have got so many blood banks. So whenever you are collecting the blood of any individual, if you are not adding an anticoagulant, means it will undergo coagulation, it will become sticky, it will become jelly, it will turn into a blood clot, and we need to avoid it. So we can avoid it by using in vitro anticoagulants. Now the thing with warfarin is, so can we use this warfarin in vitro? The answer is no. We cannot use warfarin in vitro. No in vitro use. The reason behind that is warfarin cannot affect the already activated factors. Okay, and there will be a delay in the production of action of warfarin. So we cannot use warfarin in vitro. Warfarin can be used as anticoagulant only in vivo and not in vitro. Now the next thing about warfarin is teratogenic. There is a teratogenicity. So it is contraindicated in pregnancy. So basically what happens is there is a compound known as osteocalcin. calcin. So vitamin K is also required for activation of this osteocalcin protein. So during development of a fetus, this osteocalcin is required. And if we give warfarin, it will not get activated. And if it is not getting activated, then there will be a skeletal problem in the growing baby. So that this result in a fetal warfarin syndrome. So what happens here basically here is there will be a bone growth is not seen because osteocalcin is not activated. As a result, there will be a decrease in the size of the skull. There will be decrease in the size of the nasal bone, or nasal bone is not formed properly. Eye bones are very much small, and so on and so forth. So basically, warfarin is contraindicated during pregnancy. The next and the most important thing regarding warfarin is, if we want to monitor the action, the effect of warfarin, we can monitor it with the help of prothrombin time. And one more thing by which we can monitor the effect of warfarin is with the help of international normalized ratio. Okay, so first of all we shall discuss the basic of these things. So we have got two types of clotting pathways, we know, that is extrinsic pathway and intrinsic pathway. Alright, so we have got intrinsic pathway and extrinsic pathway. We'll write here. We have got extrinsic pathway and intrinsic pathway for blood coagulation, isn't it? Now, extrinsic pathway is mainly monitored by prothrombin time, whereas the intrinsic pathway is mainly monitored by activated partial thrombin time, that is APTT, activated partial thrombin time. Now the normal value of this prothrombin time is nearly 12 to 16 seconds, whereas the normal APTT time is 26 to 32 seconds. Okay, now if we want to see average time for prothrombin time is nearly 15 seconds, and average value for this APTT time is nearly 30 seconds. Okay, now suppose we have given warfarin to an individual. Okay, so when warfarin is given, the prothrombin time should be increased. Its value should be 2 to 3 times the control value. So if the value is increased, means warfarin is working. Okay, so for checking the action of warfarin, we require prothrombin time. On the other hand, what is the use of this APTT, activated partial thrombin time, is it is used for monitoring the effects of heparin. Okay, so heparin effect is mainly intrinsic pathway, which is monitored by APTT value. Now next we'll try to understand how to monitor the warfarin therapy. We know that warfarin therapy, the effect of warfarin can be monitored by the help of calculation of prothrombin time, isn't it? Now suppose before giving warfarin, we should check the prothrombin time. Suppose in lab 1 we have checked the warfarin time, the prothrombin time before giving warfarin, and it appears to be 10 seconds in first lab. Suppose in second lab one, and in another lab we have checked the prothrombin time before giving warfarin, and it appears to be 15 seconds, and in third lab also we have checked the prothrombin time before giving warfarin, and it appears to be 20 seconds. Okay, so before warfarin means the control value. Suppose in lab 1 only, we'll say for now, we got 10 seconds. And after starting warfarin, the prothrombin should be increased. So hypothetically assuming the prothrombin time should be double. So it should be, after giving warfarin, it should become 20 seconds, the prothrombin time. So what we do is, before starting warfarin, we will measure the prothrombin time and we will note the value in the file, and then we will start warfarin. Suppose we have given some dose of warfarin, and after giving warfarin for 3 to 5 days, we will again measure the prothrombin time and it should become double. If it is 20 seconds, that means the dose is okay. If the prothrombin time after starting warfarin is still less than double, like 15 seconds or 16 seconds, that means the dose is not sufficient. So we will increase the dose of warfarin. If suppose the prothrombin time becomes very high, means the dose is very high. So we will reduce the dose. So and this is how we will monitor. Okay, in lab 1 we got 20 seconds. Similarly in lab 2, after giving warfarin after consuming warfarin and after 3 to 5 days, if we check the prothrombin time, it should appear 30 seconds. Similarly, in lab 3, before warfarin consumption, the prothrombin time was 20 seconds, and after consuming warfarin, after 3 to 5 days, it should appear to be 40 seconds. It is a normal thing. Now, we have asked a relative to get a prothrombin time before consuming warfarin, and they got it in the lab 1. Okay, and we got the value of 10 seconds as a control value. But after giving warfarin for 5 days, we again take the blood sample and ask the person to get prothrombin time, and now that person get it done in lab 3, and in lab 3 we got the prothrombin time after giving warfarin is 40 seconds. So when we compare the value, it appears to be 2 times higher value, and we tend to reduce the dose. But actually we should not. The reason is different labs gives different values. So one solution, which is a simple solution, is better to measure prothrombin time before and after giving warfarin in the same lab. Okay, so this is one solution for measuring the effect of warfarin accurately. Now this is one kind of solution. We have got another solution. The second thing that we can do is, instead of measuring the prothrombin time in same lab, we can measure another value, which is known as international normalized ratio. Okay. So this international normalized ratio, it gives the value when we compare the prothrombin time of two bloods. First is the prothrombin time of the test blood which we have sent to the lab. Okay, prothrombin time of the test blood, and second we will do the prothrombin time of the normal blood, that is the control blood. Okay, so this ratio signifies the international normalized ratio. So the laboratory people will not do one prothrombin time, they will do two prothrombin time, one in the test blood which we have sent, and second from the normal blood, and divide the ratio, the two ratio, and then the power which is given the value known as the international sensitivity index. So this is known as the international normalized ratio. The important thing is, it is a ratio. Whatever variability comes in the lab, the prothrombin time is being measured twice and they are getting divided. So the variability is finished. So in simple language, the value of the international normalized ratio will be same in every lab. So hypothetically assuming the control value here will be giving a ratio of a reading of 10 in lab 1, 15 seconds in lab 2, and 20 seconds in lab 3. Okay, so this was the control value, and after giving warfarin, the value of the INR will be in lab 1, this 10 divided by 20, it will give, sorry, a 20 divided by 10, it will give a value of 2. Next, 30 divided by 15, it will again give a value of 2. Here also 40 divided by 20, again it will be giving a value of 2. Okay, so simple thing to remember is the value of prothrombin time is different in different lab, but the value of INR is same in every lab. So we can do prothrombin time but in same lab before and after giving the warfarin, or another option is better we can do INR in any lab. Okay, so this is how we can measure the effect of warfarin. Now another important thing that we need to know in relation with warfarin is, whenever we consume an overdose of warfarin, what to do? Okay, whenever we are consuming an overdose of warfarin, yes, obviously it can result in bleeding. Even any anticoagulant in overdose can result in bleeding. So what will be the treatment of bleeding due to warfarin? Very important thing to remember is, yes, do not give vitamin K. Why? Because vitamin K, what it will do, it will activate the clotting factors. But for activation of clotting factor, it will require time. Suppose it takes nearly 6 hours to activate the clotting factor, and in that 6 hours, the bleeding will be continuous, then the person will die. So if the bleeding has started, then we cannot wait for clotting factors to get activated. So we need to give an already active clotting factors, and the already active clotting factors, that will be factor number activated factor 2, 7, 9 and 10. So the factors are now available as 4 factor complex. Okay, we have got 4 factor complex. And what this 4 factor complex contains, this 4 factor complex contains already activated factor number 2, 7, 9 and 10. So this is the treatment of choice for bleeding due to warfarin. Now, if the bleeding has started, then we need to give the 4 factor complex. However, if this is not available, then we can give a, this is first option. If this is not available, second option is we can give fresh frozen plasma. Fresh frozen plasma. And remember, plasma contains all the factors, so it will also contain the 4 factors also. And if plasma is also not available, then the last option is we could give a whole blood. Whole blood. So remember, blood means plasma and blood, so it also contains all the clotting factors. So this is how we can treat overdose of warfarin. So this is all about the warfarin, which is our first type of oral anticoagulant, an example of oral anticoagulant, that is vitamin K antagonist. Next we shall check out the thrombin inhibitors. Okay, so now moving to a direct thrombin inhibitor. You know, thrombin, what kind of factor is thrombin? Yes, it is factor 2. So direct thrombin inhibitor, we can also say it as direct factor 2A inhibitor. And the drug coming under this category is dabigatran. Dabigatran. Okay, so what is dabigatran? The first thing is it is an oral anticoagulant. And what is the mechanism of action of this dabigatran? It is a direct factor 2A inhibitor, or you can say direct thrombin inhibitor. Now recently we have developed an antidote for dabigatran. If we take overdose of dabigatran, then how to treat? So we have developed a monoclonal antibody against this dabigatran, and the name of that drug is adarucizumab. Adarucizumab. Okay, so it is an antidote which is used whenever there is an overdose of dabigatran. Now another important thing regarding dabigatran is it does not require any kind of monitoring. Like in the case of warfarin, we are monitoring the effect of warfarin with the help of prothrombin time, but no such monitoring for dabigatran is required. So we have got a fixed dose for dabigatran. So this was all about the direct thrombin inhibitor, which was the second type of oral anticoagulant. Now coming to the third and last type of oral anticoagulant, that is direct factor 10A inhibitor. Direct factor 10A inhibitor. Okay, so we will try to understand about this thing. So now regarding direct factor 10A inhibitor, the very first drug which was formed under this group was rivaroxaban. Rivaroxaban. Okay, so what is rivaroxaban? It is a direct factor 10A inhibitor. And just like dabigatran, even rivaroxaban, it does not require monitoring for its effect. A fixed dose of rivaroxaban is been available. Now, after the formation of rivaroxaban, we have developed still more drugs in this group. Some 3 or 4 more drugs have been developed, and the names are apixaban. Next, we have got edoxaban, and lastly, we have got betrixaban. Okay, so these three are a newer type of factor 10A inhibitors. Now, after this, more recently, we have developed antidotes of these drugs. Means whenever we have consumed an overdose of factor 10A inhibitor, we can inhibit its poisoning with the help of an antidote, and the name of that antidote is andexanet alpha. Andexanet alpha. Okay, so what is this andexanet alpha? It is an antidote which is used whenever we are consuming an overdose of all these direct factor 10A inhibitors. Okay, so with this we have completed the oral anticoagulants. Now very quickly we shall jump to the parenteral anticoagulants.